Oh, okay, thank you so much. So I'm gonna talk about a paper that we found to address a clinical question that we had on the floors, but it's supposed to focus more on likelihood ratios and the way that we can use them and interpret them. So just as a reminder, evidence-based medicine, it's like Dr. O says, it's the conscientious use of the current best evidence that we have available to guide clinical decision making. So clinical guidelines, they're constantly evolving based on new data that comes out in the literature, but the process of that assimilation of the latest research into kind of medical guidelines and medical canon, it's not instantaneous. So as clinicians, we have a responsibility to know how to screen for, find, interpret new high quality data. And yeah, so today we're going to be discussing likelihood ratios through the lens of a study pulled from the literature. Um, so let's start with the case. Can someone quickly read through the case? Any volunteers?
So, Sarah, can you help us reading out the case?
Sure. 77-year-old woman with past medical history of dementia, baseline AO times 2, hypertension and breast cancer, status post-lumpectomy in 2016, non-compliant with AI, admitted to medicine service from the ED with altered mental status, awake and alert but lethargic, oriented only to self. ED team discovered inadvertent acetaminophen overdose. Patient recently fired a string of home health aides and is refusing additional help at home. Was not keeping track of the number of tablets she was using for chronic back pain. Serum acetaminophen level 173 mcgs per mil on admission, LFTs in the thousands. CT head and chest x-ray negative on admission. Patient started on NAC protocol as well as antibiotic therapy in setting of dirty UA. Over the next few days, LFT is downtrending, patient afebrile, but per visiting family remains altered off of her baseline. On exam, vitals are stable. Physical exam reveals clear lungs, regular rate and rhythm, normal S1 and S2, mild abdominal tenderness to palpation diffusely, no asterixis, no focal neurological deficits, blood cultures drawn on admission are negative. Medicine team discussing need for further workup.
Thank you so much. So like I said, this is a case that we had on the floor. And, this patient was admitted from the ED and has this baseline dementia and, had this encephalopathy, was started on NAC, but we weren't really seeing much improvements in her mental status, despite starting to see improvements in her LFTs, like they were coming down well below 1,000, and she'd been on antibiotics for a couple of days as well to treat this possible UTI, but it just didn't seem like she was coming back to her baseline. So we weren't sure if we reached a point where we had to work up further. And so one of our med students who was rotating with us, was like, why don't we order an ammonia level on this person? And, as the intern, you're like, want to be able to answer the medical students' questions, but sometimes they ask really good questions that you're not sure how to answer. So like a million things are going through your head. You've previously, you've ordered ammonia levels before, like in the setting of decompensated cirrhosis, but you've never ordered it before for drug-induced liver injury, for like acetaminophen overdose. You're not sure what GI would think on that. You think back to the patient, like they didn't have asterixis on exam this morning when you saw them, and they've been on NAC, LFTs are coming down. Should you just ask your senior? Should you order repeat acetaminophen levels? You've never done that before. That doesn't sound right. You're not sure if this warrants like a neuro consult or a delirium consult. So you finally decide to just ask your senior, but then a rapid is called on the overhead. So your senior leaves the room and he leaves with the intern on call. So you're kind of like stuck with the fourth year and you're just kind of like not sure how to answer his question. So you actually have a little bit of time on your hands. You finished all your notes. This is like never happens, but you finished all your notes and the consultants have weighed in on your patients. All the to-dos are tucked away and you have some time, so you want to set a good example. You tell the fourth year that you don't know the answer to his question, but you can look it up together. And so how do you start this process of looking something up in a systematic way? We don't just want to like Google and pull up, any random article. So you think back to Dr. Zorio's first EBM lecture. You remember she mentioned something about PICO. And so who knows what PICO stands for? PICO. That's fine. So PICO stands for the patient, an intervention or an exposure, a comparison, and an outcome. And these are the different components of a clinical question that it's important to think through once something is coming up on the floors. And it's useful in the sense that defining the PICO and breaking a problem up into the elements of the PICO can help you construct a targeted search strategy and find an appropriate study or paper to answer your question. So I don't want to spend too much time on like trying to do the PICO, but this is my suggested PICO for this case. We have someone who has acute liver injury, a setting of a Tylenol overdose, and that's the patient. The intervention is, what is the value of a serum ammonia level? On the comparison, gold standard, like how we diagnose encephalopathy, it's the clinical picture overall, the signs and symptoms. Some people use scoring systems, and the outcome is the diagnosis of encephalopathy. And, like I said, you don't want to just Google something. It's easy to do that, but if you really want to find the best available evidence to answer a clinical question, you want to make sure you're surveying the literature in a systematic way. So, the Levy Library, this is the link to that. There's a link to PubMed from there, but there's also lots of resources about how to search PubMed, how to build a search strategy. Medline used to exist kind of outside of PubMed in the sense that you could search Medline directly. Now it's just searching the new PubMed. And so I think it is useful to go through some of their resources about how to build search strategies, how to combine search terms with Boolean operators, what is a mesh term and that kind of stuff. And there's this nice video for how to do that. But anyways, you search the literature with the med student, and this is your search strategy. You included a few components of the PICO, so the patient, the intervention, and the outcome. And for the patient, you combined, a couple of search terms, you used some Boolean operators. Toxicity, overdose were combined with or, acetaminophen was combined with N, and that was the patient. And the intervention and outcome were searched in the following ways. But you find this paper, it's entitled Hyperammonemia and Acetaminophen Toxicity. And you quickly read the introduction, and it seems like it does fall within the scope of what you're trying to answer on the floor. It says acetaminophen-induced hepatotoxicity can result in hyperammonemia, but it's not clear if elevated ammonia concentrations predict encephalopathy. So you decide to, give it a fair shot. You do what we all do. You open the paper, you scan the abstract, and then you just jump to the results. But then you're kind of overwhelmed because it's a lot of results, and you've seen sensitivities and specificities before, but you've never kind of interpreted likelihood ratios before. So before kind of jumping in and talking about that now, we, I think, should go through this two by two. And I know we've all like memorized this, and we're asked about this in some of our exams, and it's not the funnest thing, but I think always kind of thinking back to the way that the 2 by 2 is constructed is useful if you forget like the definitions of sensitivity and specificity and predictive value and likelihood ratio. So I'm going to quickly go over that. So to construct the 2 by 2, there's really like two main components. The first are the columns, which describe your disease status, right? So this first column is all patients who do have disease. And the second column is all patients who don't have disease. And that's crossed with the rows, which outline the results of testing, right? So the first row is all patients that test positive, and the second row is all patients that test negative. So in the intersection, you see patients that truly have the disease and they tested positive, patients that tested positive but don't have a disease, patients that tested negative but they do have the disease, and patients that test negative and they truly don't have the disease. So when we're talking about predictive values, sensitivity, specificity, likelihood ratio, I like to remember this placement because it helps me remember kind of the utility. So predictive values are calculated with the denominator that's the sum of the rows. And that's important to remember because the denominator includes patients with disease and patients that don't have disease. And the reason I bring that up is because prevalence will affect kind of these different numbers, right? It affect how many fall within a true positive group and how many are falsely positive. And so prevalences do affect your predictive values. Sensitivity and specificity, though, for sensitivity, it's calculated with the denominator that's the sum of all the individuals that have disease, right? And so sensitivity is the true positive over the sum of the true positive and the false negative. And it's the same thing for specificity. It's calculated with a denominator that's the sum of the total number of patients that don't have disease, right? So it's the true negative over the total of the false positive and true negative. Just as a reminder, so the likelihood ratios are calculated using the sensitivity and specificity. So let's jump forward. So you're probably thinking, okay, that's great, but how is this useful to me? You know, what do these different parameters explain? What is the clinical applicability of all these different measures? So I know we're supposed to focus on likelihood ratios, but I always confuse all of this all the time. And so I think delineating how each parameter is different is useful to understand the true value of likelihood ratios. So the sensitivity, we talked about this as it's a property of a test, right? A diagnostic test to detect patients with disease. So for sensitivity, let's say, we have 100 women with breast cancer. I need the mammogram to give me a positive result in the vast proportion of them to have high sensitivity. And I like to think of this as the ability of a diagnostic test to cast a wide net and capture everyone who truly has a condition, even if it also catches some people who don't actually have that condition, aka is not highly specific. Because it's supposed to raise an alarm in the physician's head that, oh, I need to consider further, I need to do more, perhaps more diagnostic testing. If we take the example of breast cancer and mammograms, do I need to maybe do a biopsy or other diagnostic testing? And then kind of continuing with this example of, breast cancer, well, how do I know who I'm supposed to give chemotherapy to? Because that's a different thing entirely. That's putting an individual through, sometimes very tough regimens that have toxicity. So you need to be sure, right? And you don't want to give treatment to someone who doesn't have cancer. So you need a test that will be negative in patients that don't have a disease. And if we go back, to the 2x2, you want the test to be negative in the group of patients that don't have, truly negative in a group of patients that don't have a disease, and that's the specificity. So you need a test with high specificity. So if being sensitive is to cast a wide net and capture everyone that truly has a condition, being specific is like using a fishing line with bait that only one specific fish species likes to snack on. And that's the end of the fishing metaphors for today. But so that's kind of sensitivity and specificity and the way I like to think of them. And the way I like to think of predictive values, so we went over how they're calculated, but I like to think of them, they're parameters that are easy for patients to digest and understand. So if we look at the definition for positive predictive value, it's the probability that the patient has a disease if the test is positive. So if they test positive for something, you tell them, the probability that you actually have this disease is this number. And that's very easy for them to understand. It's the same for negative predictive value. If they test negative for a test, you tell them the probability that you don't actually have this condition is this number. And that's easier to understand. But likelihood ratios are a little more abstract. And I think trying to explain them to patients is a little tricky. If we read the definition for a positive likelihood ratio, it's the likelihood of the test to be positive among patients with disease than among patients without the disease. And I don't what does that even mean? I have the definition right in front of me, but I don't even really appreciate that just reading the definition. So why do we need them? While predictive values can be useful measures to give patients, likelihood ratios are measures that we on the clinical decision-making side need to be aware of. in terms of how to appreciate and interpret. And this is why. So remember that the likelihood ratio is calculated using two other properties of a test that comment on its intrinsic utility, right? The sensitivity and the specificity. So the likelihood ratio is also a property of a diagnostic test. But what does it tell us? So whenever we have a suspicion of disease, we're cognizant of the likelihood of that disease, even before we do diagnostic tests, right? We say things on the floors all the time, like, you suggest as, zebra diagnosis for something, and your attending tells you, well, things are common, so that's probably not what it is. And for individual cases, you're also aware of, the individual risk factors that put that specific, patient at risk for something. So if we, again, go back to, breast cancer, we know it's a very common disease. It's the most common malignancy in women. Around 1 in 8 women will develop breast cancer. But if you have a patient, that you're concerned about a possibility of breast cancer, and they also have a family history of breast cancer and exogenous hormone use, and they've previously had chest irradiation for another malignancy in the past, your suspicion of breast cancer is higher than 1 in 8, right? And this is called a pre-test probability. Before ordering a test on the patient, you have a pre-test probability of how likely you think they have a disease. So let's go back to likelihood ratios. I like to think of the likelihood ratios as the ability of a diagnostic test to move the needle of certainty that a patient has disease, or the likelihood of disease, one way or another, from a pre-test probability to a post-test probability. So there's the formula, the pre-test odds of disease multiplied by the likelihood ratio is the post-test odds of disease. And what does this actually look like? So if you have, this graph over here, which depicts likelihood of disease, you start at one point, which is the pretest probability, which is right over here. Like, let's say that this is based on prevalence, this is based on risk factors. Before going in, you have a pretest probability. And, if you have a diagnostic test with a positive likelihood ratio, it's going to take you towards, being more certain that a patient does have a disease. There's a higher likelihood of disease, versus a likelihood ratio between 0 and 1 pulls you more towards ruling out a disease. So again, if someone has, if a likelihood ratio is 1, using the formula, the pretest probability is the same as the post-test probability, because when you multiply something by 1, it's the same. So a diagnostic test doesn't move the needle of likelihood at all in that case, and it's not useful to order. It's not going to change your clinical decision making. If a diagnostic test has a likelihood ratio between 0 and 1, it helps you rule out disease, and you move in this direction towards having a lower likelihood of disease. If a likelihood ratio is greater than 1, like I said, you move in this direction, and you have a higher likelihood of disease. And kind of the main thing to consider, I think, or like the most important message from this presentation, is the further away the likelihood ratio is from 1, the larger the change will be moving from pre-test to post-test probability. Whether you're moving in this direction, towards 0, or in this direction up away from 1, the larger the difference of that, like the further away from 1, the likelihood ratio, the more impactful a diagnostic test is on clinical decision making. And so, in the literature, they talk about a few things, likelihood ratio, a positive likelihood ratio of greater than 10, or a likelihood ratio of less than 0.1, really do move the needle in very large and conclusive ways to increase or decrease the likelihood of disease. And everything else in between, I think, warrants a discussion. A likelihood ratio between 2 and 5 is something strongly to consider. There is potential value in ordering that kind of test. And a likelihood ratio that's like close to 1, you may think twice about, the cost benefit of ordering that test. And I don't know if Dr. Osorio, if you have any thoughts about like when you would because, clinically and in terms of clinical practice, when you would really consider ordering, a diagnostic test, if something is like a likelihood ratio of like 1.5 versus 3 versus 5 versus 8, do you, have cutoffs in your mind? Do you take it case by case? What do you think?
I think and it's kind of, I did not plan this. I don't think I don't know if Raf did this with the cost and the value of care lecture right before us. So I just realized that when I joined, but I think, you answered the question in the sense that for me, it's going to be the acuity of what it is that you're looking for and the severity. I think DVT and the use of ultrasound and DQ scans always get used as like an example for at least a positive and negative predictive value. So I think for me, it's going to be the acuity of what it is that you're looking for. And then it's the clinical exam, because it's going to come down to clinical exam and the history, right? And that's where all these scoring mechanisms are being created, because in the end, it's the physical exam, the history, what is your likelihood that this is or your pretest probability that this is your concern. And then it's going to depend on the test that you're using, right? And how, what it is that you're actually looking for, from like chest pain and MI versus DVT. And so in the end, it's about the test. And this was a big issue with HIV testing. And, back in the day when we were doing ELISA and Western blots, and if something was very sensitive versus specific. And the same thing is happening with the TPPA and the RPR issue, where we have something that's very sensitive and specific, but it's also confusing a lot of people who don't recognize the TPPA algorithm. But so I think in the end, it's going to be case by case and use of what tests you're using and what is that you're looking for. And I'm going to have like a few resources that I'm going to put in after the conversation. I don't know if anybody has any questions on anything that was just discussed or wanted to add to anything. I don't know, like Raf, or it's hard because I don't want to pick on Juan and Jonathan because they're the only ones with the camera on. But
I'm gonna pick on them. No, it's okay.
I just have a few comments to make. First of all, it was absolutely planned a year ago, the high value care coordination. Like we plan every single minute of it, and it was totally not coincidental. Joking, by the way, of course, it was by chance. But talking in terms of what Nadeem was asking about, like when do you, and that's something that is commonly comes up in like the literature, if it's below 0.1, it's good to rule out. If it's above 10, it's good to rule in. And that is definitely true. But like Nadeem was talking about, this is a number that is very affected by the pretest probability. So if your pretest probability is 5, it doesn't matter if the likelihood ratio is 10 or 11, it's not going to help you like that much, right? You should question even if you're like supposed to be even testing this to begin with. Whereas if you have a likelihood ratio of 3, 4, 5, that's not as high, but your pretest probability is 50, and you're really like on the fence, and it's like a more serious diagnosis, that might be even more helpful than having a test with a likelihood ratio of 10, like when your pretest probability is low. And basically, in terms of like when or how to think about these tests, I have a chart that or a graph that I'm going to share at the end. But basically, you should think about all your diagnostic testing in terms of, kind of like a line, and like taking into account the pretest probability, you can say like, I'm comfortable enough, like Dr. O said, like given the acuity and severity of the diagnosis, that diagnosis is excluded. Whereas if your pretest probability goes a little bit higher, then you might say like, this is my testing threshold and my diagnosis is uncertain. So I need a test to either bring it down to like exclude the diagnosis or bring it up to make me comfortable enough to treat it, which is the treatment threshold. And that's kind of where the pretest probability and likelihood ratios of the test come in to, like Nadeem said, move your suspicion of a diagnosis to one end or the other of the line. And I'm going to share the table at the end.
And this is going to be opposite of what was discussed earlier, but like, think about also from an outpatient to inpatient practice, like, BNP, D-dimer, CRP, ESRs being done, when you feel like you might have a suspicion, but you may not be able to get the actual like tests done, like an ultrasound or what have you, or even be able to get an EKG. So what is it that you're able to do with these tests, and how are you going to interpret them? And is it going to push you one way or the other to have someone come in to the emergency room to get evaluated further? So, you know, that's kind of, I think for us, like in the end, it's going to be like case by case as well. But I like what Rafa said as well too. So
Okay.
Nadeem, go ahead, just because the time I
Right, sorry. So okay, going back to the results of our study, this is the main table that they pulled out. And instead of kind of like telling you exactly what happened, I do want to maybe try to see if we can get some discussion or like some kind of analysis of the data. So the first question that I have, and I'm going to pick on Juan. Sorry. Juan, so this is the table that the study produced, and we'll go into the details of the methodology, but based on what you see in front of you, and you can focus on, you know, the first column as well, but really, why do you think there are 5 sets of data? So like we have 5 sets of sensitivity, specificity, likelihood ratios. What do you think is happening here, and what is being presented to us by the study?
I think because maybe this study used different cutoffs for the level of ammonia, and maybe that's why they calculated various LRs.
Yeah, that's 100% correct. So in the methodology of the study, they say that sensitivity, specificity, LRs, predictive values were calculated for varying ammonia concentrations as a screening tool for encephalopathy. You know, they used varying concentrations, you know, and also did, you know, additional ad hoc sensitivity analysis, but that is exactly what's going on here. Here they presented a summary of all of their data. And not only that, they also looked at whether patients who had an, you know, initial ammonia level and then a secondary ammonia level, whether that increasing ammonia level was associated or diagnostic, or you know, they calculated sensitivity, specificity, and likelihood ratios of that specific thing instead of a unique cutoff for ammonia levels. Okay, so just again, you know, another question for anyone. Who can explain why, you know, the trend in sensitivity values that we see above? So notice that as we take a higher cutoff for what's considered high ammonia level, the sensitivity lowers. And you can use this like net analogy if you choose, or any other analogy that you see fit. But can anyone interpret the change in sensitivity and or specificity data? Totally fine. So it's kind of what we're talking about before. So you know, they use different cutoffs for what they constitute a high ammonia level. And when they took a lower cutoff of 80, they were capturing a larger group of individuals who may truly have encephalopathy. So they're casting a wider net and have a higher sensitivity, but perhaps a lower specificity. And as they were taking higher and higher thresholds for what they considered to be hyperammonemia, that net was getting smaller and smaller. So you see that the sensitivities drop. So more importantly for this talk is kind of going off to the right side of the table and looking at the likelihood ratios and remembering what we talked about, you know, the values of the likelihood ratios. What does it mean if the confidence interval for a likelihood ratio overlaps 1? And I'm going to ask, I'm not going to ask Dr. Osorio. Going to ask, does anyone want to answer?
I think it's not significant.
Yeah, exactly. So like looking at the, thank you, Sarah. So like looking at the utility of that study, if it's overlapping with 1, then we can't say that this, you know, this test and the likelihood ratio is statistically significant at moving the needle of likelihood in either direction, right? So looking at our data here, is there any utility for any of these cutoffs and ordering an ammonia level in this case? Does anyone want to answer? Would you order an ammonia level for this patient on the floor? And if so, why? Or why wouldn't you?
Based on this, I would say no, because all of them overlap with 1. Can you say because it's not statistically significant?
Mm-hmm. Yeah, so the confidence intervals do overlap with 1. And even in this very last row where they looked at patients that had an increasing ammonia level, even though it doesn't overlap 1, the likelihood ratio is 1.53. So it's important to consider, 1, kind of the statistical significance of the data. But even when we're thinking about things like odds ratios, et cetera, we want to think about the size of the effect, right? And for, an odds ratio of 1.01, even if it is statistically significant, it's not really going to change our clinical decision making. And it's the same for likelihood ratios. It may be 1.53, but if the pretest probability, if it's not really going to change our pretest probability and impact clinical decision making, then there's probably not a lot of utility in ordering this diagnostic test. So I think that's a good interpretation of the results that we do have. And every time you take a paper from the literature and try to use it to answer a question, you can't just take what they're saying at face value and assume that it was, that data is perfect data. You have to appraise that data. And I'm not really going to go into too much detail here, but these are some of the questions that you may want to ask yourself. Is this an appropriate study for the type of research question you're asking? How robust is the study design? Does it have internal validity? Are there holes in the way that they did the study? How applicable is it to my patient? What is the generalizability of this data to the data we would want to answer, or the cases we want to answer on the floors? And then finally, once you've done that appraisal, you have to ask yourself the question, are there alternative studies that are bigger or better or better? And so very, very quickly, this is a diagnostic study. And so for each type of study, for each type of clinical question, there's a study design that's most appropriate to address that question. So for diagnostic questions, this table, kind of explains that and says that, a cross-sectional study is appropriate. Prospective studies are also appropriate and preferred. And they also put this explanation that having a blind comparison to the gold standard diagnostic test is also would allow for an optimal study to answer a diagnostic question. And so for therapy questions, you have RCTs. For prognostic questions, you have other types of studies. Either you could do a prospective cohort, you could do case control, etc. So going back to our paper, if you read the methodology, they explain that they retrospectively pulled this data, and they selected 4 patients that had hepatotoxicity, and they went back to the charts and looked for documented grades of encephalopathy, and then used all that data to calculate the likelihood ratios. So the first question of, is this an appropriate study design? It's appropriate. There may be something else in the literature that's prospective that you may think is higher quality data, but I would say that it's appropriate to use. The next question is, how robust is the study design? And how applicable is it to my patient is the third question. And I think I'm not going to go into the detail of, really how to appraise a study design, but what I think is very useful information for us to know before we learn a little more is the University of Oxford's Center for Evidence-Based Medicine. They've published checklists that are downloadable, and they direct you to question key components of a study design. So if you go to their website, you'll see critical appraisal worksheets for every single type of study, whether it's a systematic review, a diagnostic study, a prognostic study, a treatment study. And for each type of study, there are different questions that you need to ask when you're appraising the quality of that research, right? So this is a really great way to at least just start to introduce yourself to the different components that you need to question. And while I don't want to get into the details of this too much, these are the questions that the Oxford checklist provides for diagnostic studies. And they don't only just tell you what the question is, they explain the rationale for why it's an important question to answer. And they even tell you where you're going to find that information in the study so that you can go and see, how each researcher did their project. So just looking at the first one, they say, was the diagnostic test evaluated in a representative spectrum of patients, like those in whom it would be used in practice? And then they say that it's ideal if they're tested in a full spectrum of patients, those with mild disease, severe disease. It's also best if the patients are randomly selected. And then they tell you where to find this information. They tell you to go to the methods section, and it'll tell you how patients were enrolled, were they randomly selected, and then it'll tell you where they came from, the inclusion criteria, etc. And if we quickly look at our patients in the methodology section, they talked about recruiting patients from a liver transplant center. They talked about recruiting patients who had hepatotoxicity with significantly elevated LFTs above 1,000. And they also say that they recruited patients who had hyperammonemia. So those who were above 40, had ammonia levels above 40. And so, just looking at this at face value, some questions should start to form in your mind about selection bias. Are these patients that were included in this study, perhaps sicker than patients we may see on the floor? Is the process of selecting for patients that had hyperammonemia in the first place perhaps confounding? What if you had patients that had Tylenol overdose and had encephalopathy, and they had an ammonia level that was lower than this? Those patients weren't pulled into the analysis, so it's another form of selection bias. I'm not going to go through the other questions, but I just wanted to show that the Oxford checklists are really great because they tell you what to do. Like, you almost don't have to think it through yourself. You just have to follow the checklist and go through the study. And so, the last thing is, after doing this, and you have to ask yourself, is there a bigger and better study? Because if you do want to do evidence-based medicine, you can't just pick the first study that you find. You have to go back and see, okay, well, this study had these weaknesses. Is there another study that doesn't have those weaknesses, that has higher quality or that has a larger sample size and can give you better quality data? Until we find that other study, I think the conclusion of this study that ammonia hyperammonemia doesn't accurately predict encephalopathy in patients with acetaminophen-induced drug-induced liver injury. Until we find a bigger and better study, this is the current best evidence that we have. And so we kind of just did the whole process of having a question, defining a search strategy, finding data, interpreting that data, but also asking ourselves about the quality of that data, and then deciding whether we need to go back and keep looking. So that's kind of an overview.
Perfect. Thank you so much, Nadeem. That's a great presentation. I'm gonna share a few things in a bit, but right now, does anyone have any questions about the article or Nadeem's presentation that you want to ask him? Or
So I added a few things. Sorry, it's just the internet keeps on going in and out, but I added a few things on the chat, and then I added clarify a little bit more what was mentioned regarding the likelihood ratios and cutoffs. But I think we still can be case by case and depending on each test, but that's usually just a general rule that gets accepted. So I put those two on, and I have to plug in the podcast series because that was the session I just attended, is the integration of podcasts into the curriculum. So you'll start seeing that in the research curriculum in a little bit. So looking at podcasts and having that be part of the curriculum. So go ahead, Rafa, go ahead and continue.
sounds good. So I'm gonna stop your screen share, Nadeem. Can everyone see my screen right now? This is what I was talking about before in terms of what Nadeem was asking about, when should you be testing? How should you be using diagnostic tests, and when to apply these likelihood ratios? And this is kind of how you should think in terms of, your patient care and your use of diagnostic tools while you're in the floors. And here in the middle, you have really you get the most value out of ordering a diagnostic test, right? It's when you don't know what the diagnosis is. And basically here, you want to test further, and you want to either exclude the diagnosis and make it no longer relevant to have a test, or put it above the treatment threshold where like you establish a diagnosis and you start treating the patient. And really, before ordering a diagnostic test, you need to, first establish yourself in this line, and you can see it's the probability of diagnosis. If your probability is low, you really need to be testing, like, am I really above the testing threshold? And like Dr. O said, that depends on, like, is this an MI? Is this a never misdiagnosis? Is this something that, can go along like a little bit further, and like we can see how it plays out? Then you can think about that. If the diagnosis is uncertain, then you start thinking about then you're here and you start thinking about likelihood ratios. How far is this test going to pull me one way or the other? And, like Nadeem was mentioning, is this, something applicable to my patients, using like the PICO question? Is this something that will change my practice? Those are all things that you should start considering before ordering the test. And as Nadeem did talk over the lecture, these numbers can be complicated because it's a mixture, like using likelihood ratios involves combining probabilities with ratios. So that can get like kind of complicated in terms of actually using it at the bedside and trying to apply it in your clinical practice. And that's why we come up with like cutoffs, above 10 and below 0.1 to make it a little bit easier. And it's been noticed that, like, actually, funnily enough, this is a graph that kind of shows the relationship between probability and ratios. And as you can see, like, if your pre-test probability, or if your probability is between 10 and 90%, it's actually like almost a straight line. So that makes things a lot easier to calculate, because we kind of like, they came up with sort of like a cheat sheet. And let me see, I'll show you here. But it basically, and this is in MEXAP, like this is relevant for boards, and not just that, but it makes it easier to actually use this information, like, when you're practicing. And basically, it's like, if your likelihood ratio is 2, 5, or 10, then that means like your test is going to increase the post-test probability by 15, 30, and 45%. And likewise, if your ratios are 0.5, 0.2, or 0.1, then that's going to decrease your probability by 15, 30, and 45. So that's an easy way to remember and actually start applying it to clinical practice. And just in terms of what Dr. O and Nadeem, like the debate that we started, I wanted to show, I really like this graph because it kind of helps you visualize what a diagnostic test actually does. And this is why it's extremely important, like, before you order any diagnostics test, you need to know what your pre-test probability is, because that's going to severely affect the utility of the test and the post-test probability. So this is kind of what I was talking about. Like, if your pre-test probability is close to 10 here, you can see where I'm pointing with the cursor, right? And your likelihood ratio is also 10, which we said is a very good test, then that's going to bring your post-test probability up on only to like 60. But if, in the other hand, you have a pre-test probability of 50 and your likelihood ratio for this test is only 5, you can see that like it's actually going to bring it up to like above 70 if you bring like a straight line. So that's what Dr. O was talking about, that with every test, you need to look at it in a case-by-case basis. Think, how important is it for me to make this diagnosis? How will it change my practice? And also, what's the probability of the diagnosis to begin with? And that's going to tell you, how useful the test is and whether you should, move ahead and start ordering it and using it in clinical practice. Yeah, that's basically all I want.